welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Hi everyone, thank you for joining me today. My name is Heather Howell and I'm a PGY2 emergency medicine resident at Memorial Medical Center in Las Cruces, New Mexico. And today I'm going to be reviewing the study titled Early Amiodarone or Lidocaine Administration During In-Hospital Cardiac Arrest Caused by Shockable Rhythms. I have a few objectives listed here to guide your attention while going throughout the presentation. The first one is to describe the role of antiarrhythmics in cardiac arrest, and the second one is to evaluate the risk versus benefit profile of early administration of antiarrhythmics. Here are a few abbreviations I'll be using throughout the presentation that I think we're all pretty much aware of and familiar with for the most part. The only one I want to point out specifically is AAD, which stands for antiarrhythmic drug or drugs. Starting off with a little bit of background, I wanted to cover the stats regarding cardiac arrest. So we first have in-hospital cardiac arrest or we have out-of-hospital cardiac arrest. Now, as you can see in the in-hospital cardiac arrest, the incidence is lower at 10.16 per every 1,000 admissions versus out-of-hospital, which makes sense since it's a bigger population. We see cardiac arrest happening in 140.7 per every 100,000 people. Also, not shocking results, we have an increased survival to discharge within the in-hospital arrest group, nearly 15% higher than the out-of-hospital arrest group. I do want to point out, though, that this number of survival to discharge is still pretty low, even in the in-hospital group, which further illustrates the poor mortality rates that are associated with cardiac arrest in general. Next, I wanted to take us through a recall of the ACLS algorithm that's provided by the American Heart Association. Now, I know this isn't very new information for us at all, but I wanted to focus your attention on where antiarrhythmic drugs are indicated throughout the algorithm. As you can see around the red box, it's generally after a few sessions of CPR and defibrillation for shockable rhythms, specifically ventricular fibrillation and pulseless ventricular tachycardia. And note that the algorithm states to administer our antiarrhythmic drugs after the third shock, as denoted by the 1, 2, 3 black arrows that are demonstrated here on the slides. So, why are antiarrhythmic drugs indicated in cardiac arrest to begin with? As I mentioned on the last slide, these agents correct abnormal cardiac rhythms by acting within the action potential. In combination with defibrillation, the antiarrhythmics are used to hopefully facilitate a successful conversion to normal sinus rhythm. Note that they are not found to be successful as monotherapy, and in my opinion, this may be why we don't see antiarrhythmics used early on within the ACLS algorithm. Taking a visual view of the antiarrhythmic mechanisms, we first have amiodarone, which is denoted by the yellow 4-point star. And amiodarone is a class 3 antiarrhythmic where it's going to work by blocking potassium channels. This causes prolonged repolarization within the action potential, and it also works on our QRS complex by allowing a prolonged PR interval. This is going to prevent the heart from any premature re-excitation from all these random arrhythmias occurring, and also slows conduction overall, which allows for the SA node to take control over the rhythm again and hopefully convert to a normal sinus rhythm. The second antiarrhythmic we see used throughout the ACLS algorithm is lidocaine, which is denoted by that 8-point green star. Our lidocaine is a class 1B antiarrhythmic where it works by blocking sodium channels. This is going to cause a prolonged conduction and a prolonged refractory period within the action potential. And this essentially is going to prevent abnormal rhythms from re-exciting with the hopes of them dying out before the refractory period ends so that we hopefully convert to a normal sinus rhythm. It does not really make any impact on our PQRS-T wave, but it may cause slight QT shortening. Now I wanted to take a review through some previous literature. So this first one is a double-blinded randomized control trial that was done by Lupton and colleagues. It was published in 2023, so a few years ago, and it was specifically done on out-of-hospital cardiac arrest. And the study's big point here was analyzing the effect of early amio or lidocaine administration, which they defined as less than 8 minutes since arrest. And that was in comparison to the late administration, or it was greater than equal to 8 minutes after arrest. And they picked 8 minutes because it was the mean published data for when we typically see these being used. Other than that, the study analyzed the early versus late against amio versus lidocaine, and then also versus placebo on the incidence of survival to admission, as well as survival to discharge and overall functional survival. So there was no difference found between early administration of lidocaine versus placebo, as well as no difference found between the late administration of both the antiarrhythmics in comparison to placebo. However, they did find some significance in early amio administration versus placebo for all the categories that they analyzed. So as you can see, early amiodarone increased survival to admission by about 15%, survival to discharge by about 10%, and functional survival by nearly 10% as well. This next trial is one of the most well-known articles that assesses the antiarrhythmics in out-of-hospital cardiac arrest. It's referred to as the ALPS trial, and it was done by Kudenchek and colleagues back in 2016. It was also a randomized double-blinded trial, and it analyzed survival to discharge as well as neurological outcomes across treatment groups. So in this trial, they found the average time to when they see an antiarrhythmic administered was 19 minutes. Overall, for results, they found no difference between the placebo versus the antiarrhythmic drug administration or antiarrhythmic versus antiarrhythmic, so the amio versus the lido. But then they did a subgroup analysis, and that was specifically on witnessed out-of-hospital cardiac arrests that showed a possible benefit towards using our antiarrhythmics. I think this may be attributed because if we have witnessed out-of-hospital cardiac arrest, we tend to see CPR initiated quicker, so maybe it has a little bit of similarities to in-hospital cardiac arrest. But overall, we saw a survival rate increase of amio by almost 30%, lidocaine by almost 30%, and placebo by nearly 23%. So both those antiarrhythmics increased their survival in comparison to placebo by about 5%. And then there was analysis done comparing amio versus lido in this case as well, and those were not found to be significantly different between those groups. And the last article I wanted to review with you today was one published in 2020 by Wissa and colleagues, and this one compared amiodarone to placebo for various survival outcomes. This one was a retrospective study done in Australia, so not incredibly applicable to the community in the US, but it also looked at out-of-hospital cardiac arrest survival rates. In this article, they found the optimal time to increasing survival is less than 23 minutes from administration. So if we administered in less than 23 minutes, we had an increased survival of almost 20% compared to placebo, increased discharge survival, and 30-day survival by about 15% increase as well. So as you can see, majority of the data that I reviewed with you and is available analyzes the timing and efficacy of amio and lido on survival, but it's mainly dominated by our out-of-hospital cardiac arrest trials. And as we saw from the statistics reveal, in-hospital versus out-of-hospital patient populations are very different, and they're not ones that we can compare pretty equally. So this is where the study I'm reviewing today comes into place and is of value to the current medical community. The researchers identified this gap in research on antiarrhythmics within the in-hospital arrests and wanted to evaluate the survival outcomes in in-hospital cardiac arrest patients with shockable rhythms, specifically in regards to the timing of the antiarrhythmic administration. So overall, this was a retrospective trial that was conducted in one single health system across several facilities within Missouri. The primary outcome was the rate of achieving ROSC during resuscitation, and the secondary outcome was the rate of survival to discharge. Inclusion criteria included being an adult, suffering from in-hospital cardiac arrest due to shockable rhythm, and receiving the antiarrhythmic drug administration during those resuscitation efforts. For exclusion criteria, it was patients who received antiarrhythmics prior to the arrest, had an implanted defibrillator, or had a non-shockable arrest rhythm initially before going into a shockable rhythm. For the statistical analysis, the data collected involved several continuous and nominal points, and those are reported in medians and frequencies respectively. The statistical analysis utilized a multiple regression model to analyze the association between the antiarrhythmic drug administration and shock timing against a ROSC and survival to discharge, and then any p-value less than 0.05 was found to be significant. Going into our study population, the overall patient population was rather small, and it was pooled over the process of roughly 10 years. Roughly half of the patients that they screened were excluded, with the majority of exclusions being due to no antiarrhythmic administration or administration given prior to arresting. But of the 88 patients that were included, 47 of them received early antiarrhythmic drug administration, which is defined as prior to the second shock. And then the remaining 41 patients received the antiarrhythmic after the second shock, which was defined as the late administration. For our patient characteristics, this is a table showing our key characteristics throughout the trial. So they were pretty similar across the board. As you can see, the age was pretty much around 66. And then it differentiates between the early versus late or prior to or after the second shock. Of note here, VFib was the most common rhythm at the time of arrest, with about 55% of patients presenting with that, and amiodarone was used as the initial antiarrhythmic 90% of the time in these patients. Moving into results, the median time to first, second, and third shock was 2, 6, and 9 minutes respectively. The total number of shocks was a median of 3 across the groups. If we look before the second shock, it was 1, which makes sense because we're giving the antiarrhythmic before the second shock. And then if we gave the antiarrhythmic after the second shock, the median number of shocks delivered was 4. And then the time to overall antiarrhythmic administration was 6 minutes. We see within our early antiarrhythmic group, the median was 4 minutes. And then after the second shock or late administration was 9 minutes. Moving into our primary outcome, which was ROSC achieved, 72% of these patients achieved ROSC, which equates to 63 of those surviving and then 25 of them not. The median time to achieve ROSC was 16 minutes. And when we look at the timing of the antiarrhythmic, it revealed an odds ratio of 0.21 per minute. So that means that every minute you wait to give the antiarrhythmic drug, the odds of achieving ROSC dropped by about 9%. Now, when we extrapolate the timing of that antiarrhythmic administration by the timing of shock, they found that giving the antiarrhythmic prior to the second shock had 6.5 times higher odds of achieving ROSC than if it was administered after the second shock. And both of these results were found to be statistically significant. Then for our secondary outcome for survival of discharge, 32% of these patients survived until they were discharged, which equated to 28 of them versus 60 of the patients dying. I will note that the cause of death was not reported within the study. As far as the results, the early administration of antiarrhythmic showed no real difference in survival to discharge overall. They were actually pretty darn similar between them. And then with the AAD administered prior to the second shock, there is a roughly 3% significant increase in surviving to discharge, which was found to be significant. Now for the overall discussion of strengths and limitations. So starting off with strengths, the outcomes were clinically significant to practice. I thought it was really interesting that we were looking at survival rather than just looking at did we terminate the arrhythmia as we expect the drug to do, but we looked at more so are we actually achieving ROSC and making better patient outcomes. Unstudied patient population as well, so that we haven't really seen any data done within the in-hospital cardiac arrest space, so it's definitely something that's needed within the space. And then we also see similar outcomes to the out-of-hospital studies, which kind of tells me that maybe there is some possible true benefit to using early administration of our antiarrhythmics. And then if you peek over between the strengths and limitations, I included the analysis done for about 10 years on both sides. And that was because I think doing it over 10 years really allows for a diverse group of patients, as well as through diverse periods of time. So I think of COVID, for instance. This trial happened throughout COVID, which may have made things a little bit different. But if we look on the flip side of that, over the course of 10 years, practice is always changing, and maybe there's a confounder to a change in practice that we're not aware of in their institution, or just something that's been done slightly different that may alter the data based on if we did it over like the point of 2 years versus 10 years. And then the exclusion of previous non-shockable rhythms, that really just makes sure that the data is specifically to our shockable rhythms as well, and that we're not having any sort of delay in the timing, since we would have had way further delayed administration if we went from a non-shockable to a shockable rhythm. As far as limitations, obviously with it being a retrospective trial, there's a lot of dependence on proper charting of these code blue events, leaving place for user error as well as some bias inclusion. And we also see a quite small sample size over the course of the 10 years, with only 88 patients being included. Next, we have with over 90% of the patients receiving amiodarone first, it's really hard to say if we can extrapolate this data and these results to all antiarrhythmics, or if we're specifically seeing this benefit due to amiodarone. Next, as you may recall from the beginning, our ACLS algorithm states to administer the antiarrhythmic around or after the third shock, but this study was analyzing before or after the second shock. So there's some differentiation between what the health system was doing and what our algorithm says. And then although I really liked the outcomes that we analyzed with ROSC and survival to discharge, it would have been really nice to see what was a neurological status when they were discharging, or what sort of functional survival did they have. Like, is this actually making a difference in patients' lives, or is it kind of just a surrogate marker for surviving? Next, I have post-resuscitation care not being reported, so that may differ based on changes of practice. One thing that comes to mind is TTM and how that changed within the last few years. Maybe that has some sort of impact on survival if they did it in the first parts of the study, but not the last few years of the study. And then also cause of death not being reported. I know from my experience, many patients may be made DNR, DNI after an arrest event, or they go on comfort care measures. And since that's not reported, it makes me curious what true mortality rate was there due to, like, if they arrested again or were just too unstable after the arrest, versus if we just made them go comfort measures and let them pass away peacefully. So for the overall conclusions, this study found every minute delay of antiarrhythmic administration led to a 9% decrease in achieving ROSC. Furthermore, administering antiarrhythmics prior to the second defibrillation did reveal improved ROSC achievement and survival until discharge. Okay, so what does this mean for our practice going forward? Although I think this study is pretty novel to practice, one of the first of its kind, I don't think there's enough data to make any specific changes to practice. However, when we get into like a benefit versus risk discussion in patients with active arrest, in my opinion, there's not a huge risk versus benefit because we have survival or death. Therefore, maybe it's something we consider or keep in the back of our pocket while we're waiting for more studies to come about to support it further. I do think this study shows the need for further research within the in-hospital cardiac arrest space, and I'd really like to see how these results may differ if we have an equal distribution of amio versus lido administration. I'd also like to see more functional outcomes assessed to see if early administration leads to any patient benefit. In addition, I've seen some research with the administration of like a type of prophylactic antiarrhythmic administration being done, and it's supposedly supposed to help prevent these cardiac arrhythmias from leading to arrest. So it makes me curious, if we are doing this early administration, are we going to prevent further arrhythmias within our post-resuscitation care? So that would be nice if we could see that analyzed. And then lastly, although I mentioned there's not a huge versus risk benefit discussion to be made, I believe we'd be remiss if we still did not cover the adverse effects that can happen from these drugs, or what sort of hemodynamic stability we have after they achieve ROSC going forward with these drugs on board. These are my sources, and I'll note the first source listed is the article that I reviewed today. And with that, thank you for listening and joining in with me today. What questions can I answer for you?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.